audience during. So we will mute all the audience, and please add your questions to the chat box and they will be addressed at the end of the session. One reminder is not to have side conversations in the chat box. It's against the etiquette. So please have your just questions posted there so that that can be addressed at the end of the meeting. Also, we will put in a link for a survey, a Google form on the chat box. Please make sure to fill that survey because that helps us to learn from you and see what the needs are, and then we can address them. So we're very grateful if you can do that for us. Um, and today we have a very exciting lecture, and it is an honor and privilege for me to introduce the next speaker. Kristen Rawson is my friend and colleague and a co-worker, and I've worked with her for the last 10 years. She's one of the smartest, brightest people that I know, and I enjoy working with her. And we are at PSMG very grateful to her for taking time out and spending her Sunday morning with us to give us this lecture. So that's much appreciated, Kristen. Thank you. Just an introduction for Kristen. She is a licensed and board certified genetic counselor with 18 years of experience in direct clinical patient care. Upon completing her graduate education at the University of Colorado Health Sciences Center in 2003, she started practicing genetic counseling at the Genetic Center in Orange, California, in prenatal and pediatric genetics. In 2009, she began working as an assistant clinical professor at the University of California, Irvine, where she provided genetic counseling in the context of pediatric, prenatal, and adult general genetics clinic. In these clinics, she would supervise genetic counseling graduate students in the UCI Genetic Counseling Graduate Program. And she was an instructor for the ethics and community resources courses in that program. In 2011, she was hired as a genetic counselor at Kaiser Permanente and practiced primarily in Riverside and Ontario medical centers. At Kaiser, Kristen sees a variety of patients in prenatal cancer, pediatric, and adult general genetics contexts, although her focus is in pediatrics and adult general genetics. She's also a part-time adjunct professor in the Genetic Counseling Graduate Program at the Keck Graduate Institute in Claremont, California. So without further ado, it's my pleasure to introduce have our speaker take on from here and start the presentation. I'll stop sharing now.
All right. Thank you so much for having me, Dr. Ahmed. Go. All right, can everybody see my slides?
Yes. Yes.
Okay, great. So I have nothing to disclose. So you already know the learning objectives for today are to identify the pertinent history that should be obtained during a genetic counseling visit, pediatric genetic counseling visit, and understand the typical and dysmorphic physical features that we see or that we are looking for during these visits, and then how to understand how to develop a differential diagnosis based on what we see, what we obtain during this examination. So a lot of what we do to prepare for these visits is done before even seeing the patient. So what I'll do is go through the information that's provided based on the referral, which can be as little as developmental delay, or could be even where the physician is suspecting a specific diagnosis. So we may or may not get much from the referral. So then, as much as I can, I'm going to go through all the records that we might be able to obtain regarding the patient, any other evaluations that have been done, if there's been any genetic testing done previously, just to kind of get an idea of what is going on with this patient even before they walk in the door. And then based on that information, I'm going to kind of come up with some ideas for what kind of conditions am I thinking about just based on what I'm able to obtain so far. And then based on that differential diagnosis, I'm going to then kind of think about, okay, well, what else do I need to know to figure out what, to try to tease out which of these possible diagnoses is actually going to fit the patient better. And then in what testing might I need to do. So I kind of try to prepare all of that prior to going in to see the patient. So I kind of have an idea of where I'm headed when I'm talking to the patient and during that exam. And a lot of times too, I'll even kind of ahead of time go to some different websites and resources to try to help me come up with my differential diagnosis. Gene Reviews is a really great website when you know what condition you're suspecting. So it gives you a complete diagnostic summary, kind of what are the diagnostic criteria for these conditions, what are the typical medical problems, inheritance, the genes involved. So it gives you a very comprehensive summary of the different genetic disorders. So if I already kind of know what I want, what condition I'm thinking of, this is where I'll go to make sure that I have all the genes that need to be tested for, what's the inheritance, just so I'm kind of prepared for that going into the visit. If I have no clue what the patient has, or it's very vague, I might then try OMIM. And so OMIM is a good resource when you're trying to develop your differential diagnosis, where you have different features and hopefully something maybe more specific than just developmental delay, something that you can then search for, say, if there's a certain heart defect that you want to look into, a certain birth defect, then you can search OMIM and it gives you a differential diagnosis to kind of get you started thinking about what you can be thinking about for this patient. So then while we're in seeing the patient for the first time, I'm going to be asking them a lot of different questions, trying to, again, figure out, where I'm headed with my differential diagnosis. So with prenatal history, a lot of times we're also trying to rule out different causes of things that could have caused the patient's features. So we're looking for exposures, different medications, because we know developmental issues can be caused by certain exposures. Some birth defects can be caused by different medications. So that can kind of help us figure out maybe we're not dealing with a genetic condition after all. Normal fetal movements are helpful because we want to know, was this baby moving vigorously, or was this something that we're even seeing in utero is causing the baby not to move as much? Then going into the birth history, we're wanting to see, is this baby normal? Were the growth parameters normal during pregnancy? Were there any complications, again, that could explain why there might have been developmental issues? And were there any birth defects or major medical problems right at birth that would be of importance? And then I always ask too, did the baby go home with mom, or did the baby need to stay in the NICU? So, that'll basically tell you right away, were there any major issues, or did the baby just go home and there were no immediate concerns? And then in terms of, development, I spend a lot of time on that, because a lot of times the patients are coming in for developmental delay. And so we're trying to figure out just how delayed are they? Is this something that's persisting? Is it something that's getting better? So we need to know, when were the concerns first noted? When were these milestones achieved? Is there any regression? Because if there is developmental regression, that kind of triggers another differential diagnosis for us. And then I also like to try to get an idea of, as for an older child, where they're functioning. So are they in special education? Have they had IQ testing? If they're in 6th grade but functioning at a 1st grade level, that tells us a lot. So we'll get a lot of that information from them as well. And then of course we want to know what all other medical issues are. Are there seizures, surgeries, that type of thing, again, to try to figure out what else are we dealing with for our differential. And of course, genetics wouldn't be genetics without a family history. So we always are carefully obtaining the family history. And again, a lot of times, because I have in the back of my mind what I'm already thinking of, I might ask some more targeted questions, but in general, these are kind of the gist of what we always want to find out about. And we want to see if there's anybody else in the family like the patient. How about the siblings? Does the patient look like the siblings? Were there any other babies born with multiple abnormalities? Anybody else in the family with similar features? And then, of course, we always want the ethnic background because that also plays into the physical exam. So we want to know what the ethnic background is to help us with some of the different facial features. And then for consanguinity, we would like to know that because then we know if we're more concerned about a recessive condition or not. So on to the physical exam. So just the general term is for dysmorphic features is basically we're looking for a morphologic abnormality that is outside the normal range of development. And basically you can have either a major anomaly or a minor anomaly. So major anomalies are going to be those that affect a medically important structure, such as the brain, heart, kidneys, or palate. Usually they're isolated, but they can be part of a genetic syndrome. So for example, congenital heart defect, about 90% are isolated, but 10% of them can be part of a genetic syndrome. And so often we will see patients, but not just because of a heart defect, because again, that's pretty common to just have the heart defect. But if the patient also has other issues, other birth defects or developmental issues, then you start thinking of it being a genetic condition. And minor anomalies are anomalies that occur in less than 4% of the population, but there's no medical consequence because of them. And so oftentimes we will still note these in the physical exam, but they can be normal. So it's not necessarily something that's overly concerning medically for the patient, but it's a clue for us as far as, do we think this patient might be dysmorphic or have a certain genetic condition? So one you're probably familiar with would be the palmar creases. So the picture on the left would be the normal. You typically see the three different palmar creases, but then when in certain genetic conditions like Down syndrome, those kids tend to have a single palmar crease. So that's kind of one of the more obvious anomalies that we can see, or minor anomalies. But even things like a thin upper lip, a smooth philtrum, clinodactyly of the fifth finger, which I'll show you, those are all things that, they can be seen in normal individuals, but kind of alert us a bit more to a genetic etiology. And then you have to remember too, there are normal variants, and these are seen in over 4% of the general population. They usually run in families. So a lot of times we'll ask, does anybody else in the family have this? Because then it kind of alerts us to, yeah, this is just a normal variation. And we don't really give too much thought to these. We may document them, but again, they're not something that we worry too much about. So the dysmorphology examination is done by Dr. Ahmed or the medical geneticist that you're working with. And so there are typical measurements that are taken. So of course we want a height and weight, that's usually done by the nurse. A head circumference, and usually the head circumference, those are taken a lot by pediatricians when the kids are younger, but as they get older, usually over age 3, they don't really take their head measurements anymore. So that's important for us because one of the big clues to a differential is if there's macrocephaly or microcephaly. And so that's always a measurement that we take. And when you're looking at a patient and feeling like we want to kind of document how their facial features are formed, and the measurements are a way that we can document it and even plot those measurements to see where they are in the range of normal. So we do ocular measurements, hand and foot measurements. So there's lots of different types of measurements. You can do an arm span to height, ratios. There's different things depending on what your differential is, and you're going to take a lot of those different measurements. And then a lot of it too is those dysmorphic features, and we'll go through some of that and some examples of that, but that's basically kind of looking at the patient. Do you notice anything unusual about how they look? And there'll also be a basic neurology evaluation looking for muscle tone, abnormalities, hypertonia, hypotonia. A lot of times we'll also have the patient walk so we can see what their gait is like. And then also there's this gestalt. So basically, do you just look at the patient and say, oh, I know what they have? And there are some conditions where we do that. We just have seen it so many times, we know what these kids look like. And so sometimes it doesn't take all of this documentation and everything. We could just kind of walk in the room and say, oh, okay. And so that happens sometimes. The website on the bottom of the slide is helpful just because, you know, sometimes you might come across different different terms that you may not understand exactly what they are. So this has like an exhaustive list of different dysmorphic features or different things you might see in papers or in a description of a genetic condition, and it actually gives you a picture of it so you kind of know what you're looking at as well as the description. So I mentioned already growth charts, but these are critical. We always have to make sure that our patient's growth is appropriate for their age, because this is a big key in your differential. So with every patient we see, we're going to plot the height and weight and head circumference, and sometimes even plotting other types like the eye measurements, hand measurements, those types of things we may plot as well, just to give us an idea if the patient is on or off the growth chart for that specific measurement. So for eye measurements, this is a pretty common measurement that we would take during a genetics exam. So the outer canthal distance is basically just that, the outside of the, basically the palpebral fissure measurement. So we go from the outside to the inner canthal distance, and then the interpupillary distance is, again, just that, the measurement between the pupils. So this kind of shows you just where these different measurements and how they can be different in the different conditions or the different eye issues that we see. So for the normal eye measurements, everything would be technically within the normal range. Telecanthus is a description for the outer canthal distance being normal, but the inner canthal distance is larger. So they kind of look like they have looks like their eyes are farther apart, but it's really that their eye, the palpebral fissure itself, is smaller. And then the hypertelorism is going to be where pretty much everything is spread out. So we see a larger inner canthal distance, outer canthal distance, but the actual eye measurements are typically normal. So here's just some pictures of that. So on the left, you can see the hypertelorism where the eyes are widely spaced, hypotelorism where they're close together, and then the telecanthus. So it kind of looks like they're, you know, cross-eyed because of the way the placement of the eyes. So again, these are all these terms and clues that we're going to make us think our, you know, differential diagnosis will go away one way or the other based on, a lot of times based on what the eyes look like. The other part of the eyes we look at is the position of the eyes. So in the middle, you can see that the line is more of a straight across, but if you have up slanting palpebral fissures or down slanting, then there are certain conditions that we think of with those as well. But again, these can also be ethnically based. And so you kind of, again, like back to what is the ethnic background of the patient, you have to take that into consideration as well when you're looking at the eye position. So here's kind of just a starting up at number 1, going all the way to 5, you can see how the philtrum is very well defined. And so the philtrum is the area basically right here. So from between the lip and the nose. And so you should have those creases, you should have that definition within the philtrum. You should see the upper lips and the upper and bottom lips are pretty similar as far as their size. And you can see as you go over to number 5 that you're seeing that the philtrum is becoming very smooth and the upper lip is kind of disappearing. And so, and this is also based on, these are 3 different ethnicities. You can see that it's different based on the ethnicity as well. So that's where we have to, you know, if we see a smooth philtrum, a thin upper lip, again, those are minor anomalies, but they make us think of certain genetic conditions, or they're definitely things that we're going to be documenting under our physical exam. Now, the placement of the ears is also helpful. And so we can see that the ears can be low set. So normally the ears should be going basically from the eye, the corner of the eye should go out to the top of the ear about. So that should be the normal placement. If the ear is down from there, that would be called low set. And then the posteriorly rotated, the ears should be mostly straight up and down, if not a little bit back, but sometimes they can be pretty far back, like you can see on B, that where the ears are down from where they should be and they're rotated. So that also is something that would be alerting us to a genetic condition. So hand measurements are used for a number of conditions. One, there are conditions where you can have smaller hands, you can have larger hands, you can have fingers that are either small like brachydactyly, or you can have arachnodactyly, which is really long fingers. So the hand measurements, a lot of times you can just kind of eyeball the hand and say, oh my gosh, yes, those are really long fingers or those are short fingers, but you can actually graph them too and chart, see what percentile are we seeing these hand measurements. So we can take the whole hand measurement. We can also do the middle finger length, which if you're specifically looking at different types of, finger length abnormalities being too small or too long, then we want to be able to measure that middle finger length as well. And then here are some of the abnormalities that we can see with fingers, some of which will be surgically corrected, some of which will not. So things like syndactyly, where you're actually, in this case, having full fusion of the two middle fingers. And it can either be just the skin, or sometimes it can affect the bone as well. If it's just the skin, usually they're surgically separated. But usually the kids still have full use of them. It's just that they cosmetically, they don't look normal. Polydactyly is where there's extra toes or extra fingers, and a lot of times those will be surgically removed, mostly for aesthetic purposes as well. And then clinodactyly, you can see that basically the pinky fingers are curved. And so that can be a normal variation, can be running in families, but it's also one of those things that certain genetic conditions will have that fifth finger clinodactyly. And so we definitely make a note of that. So once we've had the physical exam, once we have obtained all of the patient history, the family history, then we kind of come up with our differential. And so a lot of times what Dr. Ahmed and I will do is, we'll go back to his office and kind of, okay, what do we think it is? What are the conditions we're thinking about? If we don't have something that comes to mind right away, we need to kind of figure out, okay, well, is there a category of syndromes that this patient might fit into? Is there anything else that we can order? Like, should we get an eye exam? Should we get a brain MRI? Are there any other imaging or evaluations that we can recommend to try to help us figure out actually what's going on with this patient? A lot of times we'll do an echocardiogram for different connective tissue disorders, because if there's aortic root enlargement, then we're starting to think about a different angle of connective tissue disorders, or are more concerned about certain ones that affect the aorta, like Marfan syndrome. So this differential is something that we are constantly working on and fine-tuning, and unfortunately may not be figured out even at the end of the visit. But it's something that, for a lot of our patients, we kind of keep it ongoing as we're trying to figure out what is going on with them. So here's an example of a patient that could have come into our office, and we're seeing what's called micro or retrognathia. So basically micro means the chin is small, and retro means that it's pushed back. And so there's several different conditions that we can see with this. So we, again, are going to get all of the history, find out about the development, any other birth defects, and then kind of come up with our differential. So here's an example. So one, we could say, oh, it's Pierre-Robin sequence, which is basically a birth defect, an abnormality of the chin that's causing a U-shaped cleft palate, and that could be it. It's just basically the chin didn't form correctly, and we don't know necessarily why, not necessarily part of a genetic syndrome, but just an isolated anomaly. We would also think about a chromosome abnormality, such as 22q11.2 deletion syndrome. But then we think about, okay, those kids also have typically heart defects or other dysmorphic features. They have developmental delay. So did we see that in our examination? And then Stickler syndrome. So they have myopia, retinal detachment, So if we're suspicious for that, maybe we need an eye exam. And so that's kind of what we'll go through if we think it's a chromosome abnormality. Okay, let's go ahead and do a microarray and see if that's in fact what it is. So our differential kind of helps us figure out where are we going, what testing do we need to do in order to come up with a clear answer for this patient. So again, we're going to go back to these helpful websites because now we have a lot more information about the patient. So if we can make a better, more refined search for OMIM, since we know better about this patient and maybe what might be a feature that stands out, that would help us, as far as making a better search, because the more unique the features are, the better search you're going to get through OMIM. Something like developmental delay is not going to be useful. Or if we think we know what the patient has, we can go to gene reviews. And a lot of that too is going to be, we need to make sure that we're checking this patient for all the genes that are associated with this condition. We want to make sure that, if there's any evaluations, like do we need to do an echocardiogram? Do we need to do an eye exam? What kind of things do we need to look at for this condition that we think the patient might have? So we can use these websites many times for one patient. And then the next step would be ordering testing. Can we confirm what we think our patient might have? So first of all, we have to figure out, well, what laboratory can do this testing? Is it going to cover all the genes that we need to have in our panel? Is it covered by the patient's insurance? Does the patient have insurance? If so, how much does the test cost? And is that something that is even feasible for this patient to pay for? Sometimes we'll even try to figure out, go lab to lab, find out the cheapest way. Do they have different programs that can help the patient pay for the testing if their insurance won't cover it? If we do decide to proceed with testing, then we need to make sure that the patient and or the parent have a basic understanding of how this testing is working and what conditions are we going to be, what are we thinking about, and how are we going to go ahead and test the child. So we'll talk about what the different possible outcomes for the testing are. So say the testing comes back positive, then what are we going to do? What does that mean? If it comes back negative, what does that mean? And we always talk about variants of unknown significance, especially if we're doing multi-gene panels, because these are basically an ambiguous result where we're coming back with a spelling change or a variation within the gene, but we just don't know if it's harmful or not. And so this can be pretty confusing for parents because they think, oh, well, it came back positive. There's something in this gene that's wrong. So we have to really explain to them it's not necessarily wrong. The gene may be functioning fine. It's just that we don't really know what this means. It's just a lack of understanding, really. And so we try to give them a heads up ahead of time about these possible results so that when they come back on the actual report, they're kind of already ready for it and they're expecting that kind of result in case it does happen that way. One thing we tend to also, we want to make sure that the patient understands is that there is the possibility of finding non-paternity depending on what type of genetic testing you're doing. So a lot of times we'll ask for parental samples, like especially if we're doing whole exome sequencing, or if we're even some of these large multi-gene panels, they'll let us provide the parent sample just to make the interpretation easier and hopefully decrease the risk for variants of unknown significance. But in that, it's possible that the lab might say, wait, this isn't dad. The blood sample we got is not the patient's dad. Sometimes come up on genetic testing and can cause a lot of anxiety for the counselor, for the geneticist, and then obviously for the parents as well. So sometimes it's good to, kind of mention that ahead of time, that that's a possibility in case that was, a possibility for the family. And then we also want to just let the parents know kind of what are you getting out of this? Is there a benefit to doing this testing? Sometimes for some families, having a diagnosis is worth it. So, even though it might not really change anything, they want to know what the condition is their child has, just kind of to wrap it up and say, okay, we've known something's wrong with him for 12 years and now we finally have an answer. And for some parents, that's everything. But a lot of times we would prefer to do genetic testing for something that's going to actually change the medical management or provide recurrence risk. So if the parents want to have more kids, what is the chance of having another child with this condition? Or do we need to be screening for cancer? Do we need to be screening for aortic root dilatation? So these are definite benefits to doing genetic testing so that we know management-wise what we need to be doing for this patient. So just from my perspective, within the genetic counseling visit, once the diagnosis has been made, if that is the case in the visit, then we can kind of talk to the patient about, what condition we suspect based on the physical exam, or some people come in with a known diagnosis. And in that case, we can talk a lot about what the condition is. And we try to provide as much information as we can to the patient, both verbal and written. So we always like to give them the management guidelines, even though that's more important for their physician. But a lot of times, the parents are very much involved in the care of their children as well. So they like to have the management guidelines. Again, the recurrence risk, what are the options for prenatal diagnosis and the next pregnancy? And then also support group information. So we'll give them resources, websites. Sometimes we'll even have mothers of previous patients who have offered to talk to patients with the diagnosis. So we'll try to hook them up so that they can have those conversations and provide the support to each other. But a lot of times we'll push parents to do that just because they can learn a lot through those support groups as well. And just having the relationships with parents that are in their same situation. All right, so that's the end of my presentation. If there's any questions.
Thank you, Kristen. That was very informative. Myla is gonna look at the chat box and see if there are questions posted. But I have a question for you. In terms of ethnic background, how important do you think it is to see the parents as well? Because sometimes you would see a child that you would think may have some features that are concerning to you, but could that be due to that's in their family, that's how they look?
Right. And I think that's a lot of times we'll even ask if the parent isn't there, we'll ask if we can see a picture of the parent that's not present at the visit, because it's very important. A lot of these features, we think of as technically normal, but they could be very well normal for the family. And so as long as the child looks like the parents and the parents don't have an issue, developmental issue, or we're not suspicious of the parent also having a genetic condition, then seeing those pictures, or it's better to have them in person clearly, but that's not always possible, but we can see pictures. And thankfully, a lot of people have pictures on their phones now, so we can easily just have them, oh, do you have pictures of your other kids? So we can kind of get an idea of what the whole family looks like. So that definitely helps us. And a lot of times the parents will say, no, my kid does not look like the family members, they stand out. And so sometimes they actually realize that.
That's very helpful. Myla, do you have any questions in the chat box yet?
I just got one. Thank you. Before I begin with the questions, Kristen, thank you. That was an excellent presentation. Thank you so much for joining us today. Sabah says, how could you identify the syndrome in the baby?
So some babies, there are some genetic conditions that are obvious in a baby. So like Down syndrome, for example, we're very familiar with the physical features, facial features of a baby with Down syndrome. So we can generally just look at that baby and know. But a lot of conditions, it's not that easy. So if we don't have an idea for what the baby might have, if the physical features aren't striking enough, then a lot of times we're going to have to order some genetic testing. So usually our first go is going to be a chromosomal microarray, just ruling out chromosome abnormalities. But we may also have to go beyond that into single gene testing or even multi-gene panels or whole exome, depending on what's going on with the baby.
So I guess Saba added on to her question. She's wondering if you could identify a syndrome in a baby in a pregnancy by ultrasound.
Yeah. Mm-hmm. Yeah, and we do that too. So a lot of times we will have abnormal ultrasounds that are then we triage those as genetic counselors as well. And so we'll see the patient then kind of going on based on what they see on ultrasound. We'll usually work with the maternal fetal medicine though, because they're going to do a much more detailed high resolution ultrasound. And they're looking specifically for different dysmorphic features or birth defects that might be noted by ultrasound. So there are some conditions that we are able to diagnose prenatally, like for example, Beckwith-Wiedemann syndrome. A lot of times those babies will have an omphalocele. So if we see an omphalocele in utero, a lot of times that will tell the patient, you know, we need to check for a chromosome abnormality, but we also can check for this condition, Beckwith-Wiedemann syndrome. And so that can allow us then to diagnose that condition prenatally. It's a lot harder to do it prenatally unless there's a striking feature that we can test for, because we don't have the luxury of that physical exam and seeing all those minor things that we can see once the baby is out. But we certainly can do it prenatally too.
Thank you. So the next question is from Dr. Saqib Mahmood, and he asks, what other parts of the body should be looked at for dysmorphology besides the craniofacial and limb regions?
So we also look at the spine. You're pretty much everything, to be honest. I mean, you're looking the spine, you want to make sure they're looking for scoliosis. We're looking at limbs, like not so much like the hands and feet, but also the limbs. Like, are we seeing shortening of certain segments of the limbs, like rhizomelic shortening? Are we thinking of a skeletal dysplasia? Even certain conditions can affect the chest bone. So we can see like a pectus excavatum where the chest bone is caved in, or even just kind of the overall structure of the body. The neck can sometimes be webbed in certain conditions. So it's not, I mean, we really do look at the entire body. So it's the full, but the things I mentioned were kind of the ones that stand out or the most obvious ones, things that we see routinely, but really you also are kind of just looking overall at the body habitus too. Does the patient look proportionate? Are the arms too long, too short? Those types of things as well.
Okay.
And there's also there's also the exam of the genitalia, which can be helpful as well.
Okay, thank you. So I feel like you've already answered this question, but just in case you want to add something, another question about how to diagnose these sort of disorders prenatally so that serious birth defects can be detected.
Mm-hmm. So, I mean, most places will do like a screening ultrasound at 20 weeks, just like an anatomy scan. So that's kind of your typical kind of general screening that everybody gets. And then if there's an abnormality noted on that exam, then you would do the more detailed ultrasounds, meeting with genetics. But there's also, we do blood work. So there's different screening tests for checking to see if there's an increased risk for Down syndrome or other chromosome abnormalities. So that's another way that we can kind of initially screen for some of these conditions that we might be able to detect prenatally.
Okay, so the next question is a really good question. It's from Ambreen Fatma. How does one resolve a VUS in clinical setting and make clinical decision based on the result?
So sometimes we can't. I would say probably more often than not, we don't. And that's just because we don't have enough information to resolve it. But what we try to do is we'll get parental studies. So we want to see, is the VUS segregating in the family with the symptom or with the condition? Is it de novo in the patient? So if the parents don't have it, sometimes that will then change the classification up to likely pathogenic if it's de novo. So a lot of times parental studies will help. Sometimes we'll even, the labs will contact me and ask for more clinical information just to see, does the patient also have this or this, to try to give more ammunition to that actual result to see if it could be fitting that condition that the VUS, in the gene that we find the VUS. So we'll do a little bit of work like that. Sometimes the lab will call it a VUS and we think that maybe it is pathogenic just based on what we think about the patient, or we feel like the patient really does fit this condition. So sometimes Dr. Ahmed and I will kind of just say, we think this is probably pathogenic, but we can't say for sure at this time. So, a lot of times we will then see the patient back in a couple of years, 2-3 years, and then we will ask the laboratory for a reinterpretation of that variant just to see if it's changed over time. So sometimes it's more of like a process rather than just a one-time test result.
Okay, thank you. So the next question is from Dr. Rizwan Naeem, and it's also on variants. Can you briefly talk about next generation sequencing, NGS bases, variants, and counseling challenges? I feel like you addressed a bit already.
Sure, yeah. So I mean, the biggest challenge is that, it's really hard to understand what a VUS means, because most people are going to think like, oh, there's something on my report that's not normal, and they think it's a problem. So probably the biggest challenge is helping the patient understand what that means and that it may actually be nothing, because a lot of times the variants are downgraded to benign. So we really try not to give them too much weight unless we really think that it's a concern. But that is something that, we found that if we let the patients know ahead of time that this is a possible result, that it ends up being not quite as confusing on the other end when we're giving them the results, because they kind of already have the idea of something happening like that, that is not something that we necessarily think of as a problem.
Yeah. Christian, if you would allow me to just add one thing to that, is also the molecular genetics of the variant is important. In the lab results, they report it as if that variant is in a conserved area or not. Is it conserved across the species? How common it is? Has this been reported in a place called ClinVar, which is another website that you can go to? And I would really recommend that if you have a variant of uncertain significance, you go to ClinVar, you put the gene name and the variant, and it gives you all the different laboratories that have reported it and what their interpretation has been. So the molecular defect itself is something that you should also look up to see what is the evidence or what literature support has been with that particular variant. And then you can make up your mind as well, like, do you think, yes, it's still a variant, but do you think it may be causative or not? So the molecular description is important to look as well.
Okay, thank you, Dr. Ahmed. Next question is from Rafia Gul. If one of a monoamniotic twin has a syndrome and the other is apparently normal, should we offer testing to the apparently normal twin?
I mean, it kind of just depends on what the condition is and what the concern is. I don't know, Dr. Med, do you have more insight into that?
Well, I think the question was if they are identical twins, right?
Yeah.
Do we need to? We come across this just the other day. Christian and I had two patients that it was 6-year-old boys. They looked identical, but the mom wasn't sure. And if you're pretty sure that they are identical and it's confirmed, then there's no question. You can just do testing for one, and you would assume that the other would have it. And if they have the clinical features, then it's pretty much done deal. You don't need to spend extra money to do the testing. But in case that you have patients that you're not sure if they're identical or not, they may look similar because they're siblings, but sometimes it's hard to say and you don't have that history. And it's a condition that can cause problems later on in life, then might as well go ahead and test them just to make sure and have a peace of mind for the parents. So it really depends on the clinical situation and what that condition is. Then you may decide if you want to do the testing for the twin or not.
Thank you, Dr. Ahmed. So our next question is from Misbah, and she is saying, thank you so much, Kristen, for this wonderful lecture. As you talked about VUS, variants of uncertain significance, how do you usually tell the parents about the uncertainty, as parents had lots of hope from the test? So I know you've sort of discussed this and you talked about the importance of pre-test counseling, but in case you have anything else to add, or we can move to the next one.
Yeah, I mean, I kind of give it to them as like, we kind of say it's like having a negative result, unless, like Dr. Ahmed said, if we're suspicious that this VUS might actually be an issue, we just keep it very open with the parents, and that, this is a possibility, but we're just kind of put it on the back burner. We're just not sure what this really means. But sometimes we do give it more strength, or, so it really is more of just a conversation with the parents, being very open with what we're finding. And then we also try to, reassure the parents that rarely is a genetic result going to actually change what we do for them, unless they're talking recurrence risk or, a major medical problem. If we're talking a kid with autism or intellectual disability, it's more of just kind of like a search for knowledge of what is going on versus something, we wanted the parents to know that their child is not harmed by not knowing what they have. It's more of just trying to figure it out for them, and letting the parents know that we're going to keep trying. So even if this result now doesn't tell us, we're going to keep trying, and we'll look into it in a few years, and hopefully the technology will improve and our knowledge of the genes will improve. So it's more just making sure they really understand kind of where we are, and we're just very open with them as far as, the process of trying to come up with a diagnosis. But unfortunately, sometimes they are disappointed.
Okay, thank you. So the next question is from Sabah Mahmood, and she is saying, what could be a suitable statement to satisfy parents about a genetic anomaly or maybe even a syndrome that is not curable?
I try to think of it more so as, especially when you have like a little baby in front of you, and the parents are very scared, I try to be more positive about it. Like, because we know the baby has this condition now, we're able to look for these different things. We're able to keep an eye out for these medical problems that might come up. We're able to put the child into developmental programs, that had we not known about this diagnosis for several years, we wouldn't have had all of this opportunity for this baby. So I try to take a more positive spin on it, and, reassure the family that we're there for them. We're going to be with them through this process. We're going to help them make sure the baby's taken care of. And because we know what the baby has, it gives us, we're empowered to do a better job with the child. So I try to take us like more of a spin like that, be more positive, kind of show the parents what you're gaining by having this diagnosis for your child.
Okay, thank you. The next question is by Dr. Ansar Rabia, and she is asking, for dysmorphology in autism, there are different scales or scoring systems used for categorizing them as being dysmorphic. What is the clinical significance of dysmorphology in terms of prognosis and its correlation with genetics?
So I wouldn't say probably has too much to do with prognosis. It's more of a tool to help us come up with the diagnosis. I don't know, what would you say, Dr. Ahmed?
I agree with you. The question is it plain simple autism, or is it what we call autism plus? And autism, as we all know, that it's a diagnosis that is basically a manifestation of symptoms that the child manifests. And there's a full criteria, the DSM criteria, based on which the diagnosis is made. So our big question is, when we see autistic kids, is this plain simple autism, or is this a genetic syndrome that is presenting as an autism? Or even if it's plain autism, can we find a specific genetic etiology for that? So those are three questions. So this one category is where we can't. We just, they're just autistic kids. They are otherwise very normal looking. There's no dysmorphic features. They just have the communication issues. And then there are kids who have autism and then they look dysmorphic. And when you have that two combination, normally plain autism should not be dysmorphic. But when you have that, then you wonder if there's an underlying genetic etiology, and then there are all these multi-gene panel for autism that we do and try to find out. And sometimes it's just hard to tell what genetic condition it is. Or even if they look normal, if there are multiple family members in the family who have autism, 3 kids who have autism, then you would think that there's some genetic component to that. They are having multiple kids who have autism. So in that case, also you suspect a genetic etiology, and you try to figure out for the family to try to see if you can find something that would give them an answer. Does that answer the question, Kristen? Anything to add to that?
No, I think that, yeah, I think the physical exam is just one of the tools that we use to help guide our differential diagnosis and testing.
Right. Okay. Thank you to the both of you. And the next question is from Sabah Server, and I'm not. I think I know what she means, but if not, Sabah, then clarify your question. But I'm going to ask it like you've written it. If we have twins, then what precautions like radiation would be followed to avoid any abnormalities? And I'm guessing that maybe Sabah is asking about during pregnancy, any sort of teratogenic exposures such as radiation. If not, Sabah, then maybe clarify the question in the chat, and I can re-ask it.
I mean, teratogens are very important. That's why, we always ask that as part of our history, taking the prenatal history, because that definitely can cause certain features that we might think are syndromic, but in reality, it's from a medication, or, significant radiation can cause microcephaly. So then you're thinking, oh, well, maybe it's a syndrome. Well, no, the baby was just exposed in utero. So that's very important to make sure you get that history as well.
Okay, so the next question is from Hamza Asghar, and he is asking, if a baby does not show any physical abnormalities, but the baby has the syndrome, then how can we identify it?
I mean, usually that would be by genetic testing, would be how you would identify it then. I don't know why, I'm not really sure of a situation where that would happen, aside from like, say, it's something running in the family, and then we test somebody for it, like test a child for it that maybe doesn't have symptoms yet. So usually I would say genetic testing would really be the only way you would notice if somebody is otherwise looks normal.
Okay, that is the end of the questions that I see in my chat. Thank you so much, Kristen. You did such an excellent job answering those questions. I see that Dr. Sikandar has raised his hand. Dr. Ijaz, do you see that as well?
No, I have not. Dr. Sikandar, do you want to just put your question in the chat box, or I don't know how to? Yeah, I see that you have raised your hand, but I don't know how to unmute you because I don't have that privilege.
Can I ask a question?
Sure, go ahead.
Are you listening?
Yes, we can hear you.
Yes, thank you very much. It was an excellent lecture. My question is, I am a pediatrician and was a humble student of genetics. I just want to inquire that how much it cost for whole exome sequencing in USA, and how frequently do you order it for your diagnosis of the pediatric patients?
We order it occasionally, I would say. I don't know about, I can't think of like maybe once a month, if that. Because we actually, a lot of times we reserve the whole exome for our pretty complicated patients where maybe a multi-gene panel isn't sufficient because they have maybe different features, like say if it's, autism, intellectual disability, we can do a panel for that. But if they have a heart defect, well, that doesn't really fit in with intellectual disability. So we would probably go to an exome for that. Dr. Ahmed, do you know how much they are now? I mean, it really depends on the lab.
It depends on the lab. Different labs have different prices, and when you do whole exome sequencing, you have the choice of just doing that proband, the one who has this, or you can do both the parents together. We call it trio, and there are different prices for that. And within even the prices, there are two set of prices. From Pakistan's perspective, Kristen, you may not know that we don't have insurance here,
Right.
so
Yeah.
people have to pay out of pocket. So if there's an out of pocket cost, then the cost is lower by the laboratories. They charge less if the patient is paying for it. But if there's institutional billing where an institution is paying, then the prices are different. So for every lab, first you need to know what kind of testing you're doing and are you doing trio or not. And even then the price could be different. But you're looking at least $2,000 plus ballpark for most of these whole exome sequencing. But recently, we have been in contact with certain labs who have started offering the whole exome sequencing for one person for about $800. And we are in communication with those labs to provide services to Pakistan, where they are ready to do this whole exome sequencing for about $800 to $900 for the proband. If you add the parents, they might go to $1,000 or something like that.
That's great. I mean, it's still a lot of money though.
It's still a lot of money, especially
Yeah.
from Pakistan perspective. It's quite
Yeah.
a lot of money.
So we have one other question in the chat from Dr. Rizwan Naeem, and he's asking any known phenotypes with toxicology.
You mean like teratogen exposure type of?
Yes. Mhm.
Yeah, there's a lot of them. I mean, the biggest one would be fetal alcohol syndrome, where there are certain features that we can see that where it physically affects the developing fetus. There's one medication that's used for acne, which is called Accutane. That one can cause birth defects that looks a lot like a DeGeorge syndrome or 22q deletion. There's CellCept, which is used for, I believe it's a bone marrow, it's a immune suppressant for transplant patients. And that can cause features that look a lot like a Goldenhar syndrome type of thing. So definitely the medications that are used during the pregnancy, it's critical that you know what the patient is on, because that can make a big difference.
Okay.
And these days there was this Zika virus that was going on,
Oh,
and in South, southern countries, there's this mosquito that was biting people, and the Zika virus was causing microcephaly, and for
Yeah.
a long time they couldn't figure out what was causing this, a lot of microcephaly in newborn babies, and then they figured out it was due to this vector, the virus. It's interesting.
Mm-hmm.
Okay, I think we're right at the top of the hour, and I don't see any additional questions in the chat. So with 1 minute to spare, I just want to thank you personally, Kristen. That was just a very, very informative and well-delivered lecture. And Dr. Ijaz, if you want to say anything for the
No.
closing.
Same deal. Thank you, Kristen. We really appreciate it. This was
You're
really
welcome.
nice. Actually, our next lecture is going to be on genetic syndromes as well that we expect. So will be a great segue, because now people understand what the basic physical features are that they have to look for and what type of testing, and that would then go into discussing common genetic syndrome. So we really appreciate your time, and thank you so much.
Sure. You're welcome. Thanks for having me.
And I just want to say thank you to Mr. Yunus for setting this all up for us, and really appreciate his help with all this audiovisual things. So appreciate it. Thank you so much.